This is Eric Michael Lloyd. I have a master's in psychology. Not yet have taken the EPPP. Um, my concentration is neuropsychology. I want to read something from effectivehealthcare.ahrq.gov, the Effective Healthcare Program. This one is about treatments for adults with schizophrenia. This was published, the research protocol was published August 17th of 2016. I'll just read this protocol and then I'll also read the systematic review that was published October 26th of 2017 right after it, or at least the introduction of this one, and then the table of contents, and then the actual systematic review that was published in October 26th of 2017 for treatments for adults with schizophrenia. Background and objectives for the systematic review. Schizophrenia is a serious mental health illness with potentially devastating effects on both patients and families. As a lifelong illness that frequently presents during early adulthood, it is associated with negative outcomes throughout the lifespan of affected individuals. The most recent version of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, version 5, DSM-5, has continued the trend of clarifying and simplifying the diagnostic criteria for schizophrenia from DSM-3 through DSM-4 without changing the defined patient population among the editions. Currently, DSM-5 defines schizophrenia as the presence of two or more of the five core symptoms: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms, with at least one of the symptoms being delusions, hallucinations, or disorganized speech, with symptoms being present for at least 6 months. Lifetime prevalence is approximately 0.3 to 0.7%, with onset most commonly between late adolescence through the third decade. That's interesting. Brushing up on the lifetime prevalence, which is only 0.3 to 0.7%. That's the likelihood of keeping or having that diagnosis for a lifetime. With clear mechanisms of disease and therefore means of prevention remain lacking. While clear mechanisms of disease and therefore means of prevention remain lacking, active lines of research seek to form hypotheses that connect known risk factors, genetics, season of birth, urban environments, to measurable neurocognitive deficits, prefrontal cortical deficits, and treatments shown to be effective. Dopamine antagonism. The differential diagnosis is broad, with affective psychosis during depression or bipolar disorder, and substance abuse comprising the bulk of the differential, with multiple other conditions that can lead to psychotic symptoms that are ruled out by appropriate use of diagnostic criteria and assessment. Antipsychotic medications, primarily effective via dopaminergic antagonism, usually provide the foundation of treatment, but non-drug treatments are almost always necessary to complement the benefit of antipsychotic medications. Both pharmacological and non-pharmacological treatments for schizophrenia can result in meaningful improvements in a variety of outcome areas, including psychiatric symptoms, functioning, for example, employment, social or service utilization, for example, hospitalization or crisis services, legal system involvement, quality of life, self-harm and aggressive behaviors, treatment engagement and retention, and co-occurring substance abuse. Ideally, improvements in symptoms translate to long-term, clinically relevant positive changes in other outcome areas, functioning outcomes, with limited and manageable adverse effects. For example, sedation, likely consistent with limited understanding of the causes and best treatments of schizophrenia. Prognosis remains poor, with nearly 80% of patients continuing to require varying forms of social support throughout their lives. I guess that's due to limited understanding and best treatments. While pivotal trials of antipsychotic efficacy are limited to measurement of symptom reduction that may be of unclear clinical relevance, measurement of other important clinical outcomes that reflect improvement in social and occupational functioning are necessary to provide patients and families with the best management options possible. Historically, the wide array of antipsychotic drug treatments has had a mixed impact on long-term outcomes, such as the ability to have consistent employment, successful interpersonal relationships, and maintain independent living, and serious concerns about adverse effects. For example, tardive dyskinesia, weight gain, and diabetes, and dyslipidemia for some treatments. A patient's ability to adhere to and persist with treatment long term is crucial and can vary by treatment and patient characteristics, among many factors. Older, first generation antipsychotics, FGAs, such as haloperidol, have proven efficacy, but adverse effects such as extrapyramidal symptoms and, in some cases, tardive dyskinesia often limit long term adherence. Second generation antipsychotics, beginning with clozapine, were introduced as having equal or better efficacy and the hope of fewer extrapyramidal symptoms and lower risk of tardive dyskinesia. But SGAs also have potentially serious adverse effects, cardiovascular and endocrinologic adverse effects, that make their overall risk-benefit profile less clear-cut than anticipated. Since the American Psychiatric Association's APA most recent guidelines for treating adults with schizophrenia in 2004 and a focused update in 2009, important developments have occurred both in the pharmacologic and non-pharmacologic treatment interventions for schizophrenia. There are at least 5 new antipsychotics and 5 new long-acting injectable formulations approved in the United States since the 2009 APA guideline update, and as many non-pharmacological, for example, psychological treatments developed, refined, or expanded in recent years. Given the ever-evolving nature of schizophrenia treatments and their potential for meaningful benefits and significant harms, up-to-date guidance based on comparative evidence is needed to determine the best treatment approach for individual patients. There are several challenges remaining in the evidence base on treating adults with schizophrenia. These include evidence on effectiveness of complex interventions such as combined pharmacotherapy and psychotherapy, long-term benefits, for example, employment and social relationships, with competing interventions, using consistent definitions of these outcomes and valid ascertainment methods. As there is no cure for schizophrenia, achieving these long-term outcomes is tied to patients' ability to continue with treatment over the long term, even lifelong. As such, differences among the interventions in the ability to continue treatment may be important in selecting treatments. Equally important in selecting among competing interventions for a specific patient is consideration of patient-level characteristics that may affect the outcomes, including age, duration of symptoms, severity, and other psychiatric or medical comorbidities across a fairly diverse group of interventions. For example, treatment of negative symptoms, diminished emotional response, lack of interest, may differ from treatment of positive symptoms, hallucinations, and delusions. Treatment considerations will vary across the lifespan, and the success of any given treatment or combination of treatments depends on the balance of benefit and harm. Treating patients aggressively early in the disease is thought to improve long-term outcomes, although overly aggressive treatments, particularly drug treatments, may result in adverse effects. Additionally, substance abuse, tobacco, alcohol, illicit drugs may begin early on for patients with schizophrenia. And in these patients, successful treatment of schizophrenia involves consideration of this comorbidity as well. In middle age and older patients, the metabolic effects related to both the disease and drug treatments become concerning. Epidemiologic studies have found an association with obesity, elevated lipids, and shorter lifespan, and several antipsychotic drugs are known to increase these risks. That's interesting. I didn't know about that. Epidemiological studies have found an association between obesity, elevated lipids, which is fats, and shorter lifespan. And several antipsychotic drugs are known to increase these risks. Older patients may have increased risk of mortality and require antipsychotic dosing changes with age. Across all age groups, primary goals include diminishing core illness symptoms and reducing relapses of acute psychosis. However, physical health comorbidities can present challenges requiring modification of the treatment plan. This comparative effectiveness review will provide a comprehensive review of current evidence that can help the APA and other organizations prepare updated guidance on how to treat patients with schizophrenia. The review will synthesize evidence on the effectiveness and comparative effectiveness of pharmacologic and non-pharmacologic treatment strategies for treating patients with schizophrenia, and will also highlight areas of controversy and identify needs for future research in the management of schizophrenia. So it does have some of the key questions here and some of the treatments and medications as well. I'll go ahead and read some of these. Key question 1: what are the comparative benefits and harms of pharmacological treatments for adults with schizophrenia? Um, what are the comparative benefits and harms of pharmacological treatments for adults with schizophrenia? How do the benefits and harms of pharmacological treatments for adults with schizophrenia vary by patient characteristics? Patient characteristics include age, sex, race, ethnicity, socioeconomic status, time since illness onset, prior treatment history, co-occurring psychiatric disorders, pregnancy, etc. Key question 2A: what are the benefits and harms of psychosocial and other non-pharmacological treatments for adults with schizophrenia? Key question 2B: how do the benefits and harms of non-pharmacological treatments for adults with schizophrenia vary by patient characteristics? Patient characteristics include age, sex, race, ethnicity, socioeconomic status, time since illness onset, prior treatment history, co-occurring psychiatric disorders, pregnancy, etc. Populations, interventions, comparators, outcomes, timing, and setting. Populations: adults with a diagnosis of schizophrenia, including those with co-occurring substance use disorders, and including those experiencing a first episode of schizophrenia, including those with schizophreniform disorder. Key question 1. At least 90% of patients must have been diagnosed with schizophrenia. For studies, specifically on harms of antipsychotic drugs, populations can be mixed doses as the harms are not population specific. So this goes into how to set up the studies and how to analyze the studies once they are compiled and once the review is completed, and how to complete the review based on the standards that they have here. Um, I'll go ahead and just read the first two sets here. This might be helpful regarding number 1, antipsychotic medications. So these are two different types of interventions. Antipsychotic medications, key first generation antipsychotic drugs. Fluphenazine, haloperidol, perfenazine. That includes extended release IM injection formulation, as stated above earlier. Second generation antipsychotic drugs, as also mentioned in the background section that I read earlier. What is that? Aripiprazole, acenapine, brexpiprazole, claritrazine, clozapine, lopidolol, loperidone, lurasidone, olanzapine, polyperidone, quetiapine, risperidone, ziprasidone. These exclude short-acting injectables as they are generally only used in emergent acute conditions and on a short-term basis, hours to days. These are psychosocial and other non-pharmacological interventions. Assertive community treatment, assisted outpatient treatment, cognitive behavioral therapy for psychosis, CBTP, cognitive remediation, family psychoeducation and behavioral management, illness management and recovery, IMR toolkit, integrated treatment for co-occurring dual diagnosis substance use disorders, intensive case management, peer support and peer delivered services, social skills training, supported education, supported employment, supported housing, other interventions including combinations. Okay, so I'll just go ahead and read the next part, which is the systematic review that came out October 26, 2017. This thing's taking a while to load up. I'll just end the video there and put the next video with the systematic review, which is published October 26, 2017, and it's called Treatments for Adults with Schizophrenia. Thank you for your time. I hope this helps anyone who it need to. Thank you, or who can benefit, and families as well.